Thomas, so she's going to tell us about cardiac sarcoidosis.
Hello, so I'm here to talk about diagnosis and monitoring of cardiac sarcoidosis. I have no conflicts. So quick whistle-stop tour through sarcoidosis, what it is, how we diagnose it, what we see on imaging, how we treat it, how we monitor response. So quickly, this is sarcoidosis under a microscope. We know that it's an inflammatory disease. It can be multi-system. So the histology shows a non-caseating granuloma. What that means is you have this core of the multinucleated giant cells surrounded by this layer of lymphocytes and epithelioid cells. So this deposits itself in the organs and causes the problems. It normally affects the lungs, so most people, more than 90% will have it, but we do know there's cardiac involvement in about sort of clinical involvement in 5%, but on autopsy studies, there's probably subclinical involvement in up to 30%. It's not particularly common. Prevalence is about 1 to 5 in 100,000, depending on the population. So why we care about cardiac sarcoidosis? So it's quite a hard one to diagnose, quite non-specific symptoms, which include chest pain, breathlessness, and palpitations. However, in a fairly large proportion of people, sudden or aborted cardiac death is its first presentation. And for that reason, early diagnosis is crucial. So the gold standard is endomyocardial biopsy. To get what I showed you on the first slide, you do an endomyocardial biopsy where you thread a catheter up through the vein into the right side of the heart, where you then have these little claws that take an actual sample of the heart tissue to put under the microscope. However, there are problems with it. We know that this has quite low sensitivity. Cardiac sarcoidosis is a patchy disease, so if you sample an area that doesn't have it, it will come back as negative. And it is an invasive procedure with a complication rate. Additionally, we also don't do it very often. And for this reason, we tend to use consensus criteria. What they do, they use a combination of clinical criteria and imaging criteria, along with positive extracardiac histology. So normally that will be tissue biopsy from the lungs or lymph nodes. And there are several different versions circulating. We tend to use the Heart Rhythm Society developed in North America. So what some of these symptoms are. So cardiac sarcoidosis seems to go for the electrical circuitry. So you can get high-grade atrioventricular block. This is 3-to-1 heart block. You get ventricular tachycardia, which is one, of course, we're very worried about. And another of the criterion is treatment-responsive cardiomyopathy or AV block. You treat it, it gets better. So the imaging criteria, so on MRI, you can use late gadolinium enhancement or T2 prolongation. So this is showing late gadolinium enhancement where the white is the scar tissue, black is normal myocardium. And the T2 prolongation is the T2-weighted edema-sensitive techniques. Positron emission tomography or PET, so this is FDG as a tracer, and you get this patchy uptake reflecting that it's a patchy disease. And you can also get structural changes such as reduced left ventricular ejection fraction, thinning of the basal wall. So I'm just going to go through some of the patterns you can see. It's a very variable disease. Each patient will look a bit different. So in cases where there is inflammation but no scarring, you get this. So you get absolutely no evidence of scar. You can get a myocarditic pattern where you get this subepicardial enhancement and also this patchy diffuse uptake in the lateral wall in this case. This is a more distinctive pattern for sarcoidosis. So you get this patchy enhancement which doesn't really respect any particular pattern. And one of the most characteristic signs of cardiac sarcoidosis is the hook sign and the triangle sign. So you can see at the top you have RV and LV enhancement which goes into the septum. And at the bottom, you get this sort of triangle look. Quickly diverting to parametric mapping, which is the edema-sensitive techniques. So this is a T1 map and a T2 map. Every single pixel has a value in milliseconds. Normal myocardium has a normal range. So you can see here that this is a patient who's got late gadolinium uptake in the lateral wall, but also has raised T1 and T2 values, indicating active inflammation as well as scarring. So obviously we heard quite a lot about PET just now. This is going to be particular to FDG PET. So the way this works, this is a glucose molecule which has had radioactive fluorine molecule attached. So what happens, instead of looking at increased water content, we're looking at very metabolically active immune cells. So the immune cells are recruited to the site of sarcoidosis. These are using lots and lots of glucose. You inject the FDG and wait 60 to 90 minutes. The FDG gets taken up by the immune cells. And if you do a concurrent CT or MRI, then you get anatomical information. This will give you a range of patterns. So here you can see that clearly there is no active inflammation. They could have scarring, for instance, but there is no inflammation. Then you get this patchy focal uptake. So you can see here the red indicates there is a lot of metabolic activity with lots of glucose. You can get a focal on diffuse pattern. So you do still get these areas of focal uptake, but the myocardium itself is also taking up some glucose. And finally, you can have this diffuse pattern where there's no focal uptake, but there is this overall uptake, which could indicate a failure to suppress as well as widespread inflammation. What I mean by failure to suppress, so the myocytes are also very metabolically active, and they're also using glucose. So you have to convince them to use fat as their energy source instead of glucose. You can see here on the right, this is someone who has had no preparation whatsoever. There's a complete whiteout. You could not see any inflammation whatsoever. So you have to put them on a special diet to get that picture on the left. What that is a 24-hour high-fat, low-carb diet, which is essentially an Atkins diet with a 12-hour fast prior to scanning. However, even when you do the best dietary preparation, you can still have fairly high rates of failure suppression, up to 10 to 15%. So how you investigate for it. So the European Society of Cardiology and American Heart Association have both recently come out with the guidelines on how to do this. So in patients, for instance, who have got sarcoidosis elsewhere, in those who have got cardiac symptoms or elevated cardiac biomarkers that make you suspicious, you go for cardiac MRI as your first-line test. And here you're looking for late gadolinium enhancement in a pattern consistent with sarcoid, though T2 weighted imaging can be supportive. If you have high clinical suspicion, or if you think actually it's positive and you want a baseline PET, you can go on to do a PET at this point. And here you're looking primarily for that focal FDG uptake pattern that I showed. And then we have some slight divergence in the guidelines. So you can either discuss it in MDT, or you can be using that diagnostic consensus criteria to work out who you think has it or doesn't. And we've recently had some myocarditis guidelines, which were mentioned this morning, and you can see that MRI and FDG are both a 1B recommendation in those. Interestingly, CMR as a first-line test is because it's a great rule-out test. So this is looking at late gadolinium positive, late GAD only, not T2 weighted imaging, but a meta-analysis of 1,300 patients showed that if you have an MRI with no late GAD, then your chance of all-cause mortality of ventricular arrhythmia is very low. So in terms of treatment, we have a pretty low threshold to treat for cardiac sarcoidosis. That's because these patients have a very high risk of arrhythmia. And also we find that if you don't treat them, they don't tend to get better. Some slight divergence in the guidelines. So the ESC will say that any sign of inflammation, usually on FDG PET, is sufficient to treat. But the AHA wants some sort of clinical manifestations as well. So how you treat, if they have arrhythmia, you would do an ICD as usual. It's a slightly more grey area for primary prevention. These patients are at much increased risk, but there is this grey area in those who have not yet had an arrhythmia, but you have sufficient reason to think they might. And those will be people who've got quite a lot of late gadolinium enhancement, those where you can provoke a ventricular arrhythmia during your EP study. Immunosuppression, so this is a bit of an evidence-free zone. We have no RCT-based evidence to guide therapy. We normally put prednisolone in as a first-line agent, and then if there's not much of a response, you can add a steroid-sparing agent. And currently PET is recommended in these guidelines for monitoring. We tend to maybe go for about 6 months, but actually anywhere between 3 and 12 months has been suggested. So you can see here, this is someone who has quite extensive sarcoidosis, who following prednisolone has had complete resolution. But the picture can be a little bit more unclear in those where you have less response. So here you tend to use SUVs or standard uptake variables. And you can see here that the max has fallen from 15.3 to 8.4. Now, of course, I have alluded to PET's disadvantages, in particular this failure of suppression. So there is this growing interest in looking at MRI monitoring. So this is T2 map in someone before and after having steroid treatment, and you can see there has been a significant fall in T2 values. So to summarize, cardiac sarcoidosis is rare and difficult to diagnose. We normally diagnose it with cardiac imaging and consensus criteria, usually monitoring with PET, though you do have to bear in mind the ionizing radiation with the high failure rate. And so CMR may be a promising choice for monitoring in future. Thank you.
Any questions from the audience? I have a couple. So what order do you do things? If you've got a suspicion of cardiac sarcoid, what do you do first, the MRI or the PET scan?
The MRI generally. So because of the lack of ionizing radiation, because it's a great rule-out test. So if you have suspicion, the MRI is absolutely pristine, then I would say a lot of the time you go on to a PET, but sometimes you don't have to. So it tends to be the one we go for first.
Okay, and then the second question is, how do you differentiate true uptake on the PET scan from physiological uptake on the PET scan?
That's a good question. So I think if you have this patchy pattern that I show you, where you've got it in several different places, that would be more inclined to think that that was true. Though you can, as you know, if you have failure of suppression, but it's not throughout the whole heart, if it's in a single point, there is no standardized cutoff between what's physiological uptake and what is pathological. So I think you probably need to have more of a holistic viewpoint, looking at what the MRI shows, what the ECG shows, and try and put everything together.
Yeah. I mean, my PhD, I did FDG PET in aortic stenosis patients. So they did not have sarcoid, but by that diffuse criteria, about 20%, you could have diagnosed cardiac sarcoid in my aortic stenosis population.
Extra cardiac biopsy.
No, it's just to say that they definitely didn't have sarcoid, but it's just to say that the physiological uptake can fool you. And I think we just got to be really careful. Like if the MRI is normal and there's something on the FDG scan, I think you need a really high threshold for saying that is actually sarcoid.
Yeah, good point.
Yeah.
The perfusion scan, I think, also plays a role in this. We talk about that quite a bit in our MDTs. What do you think the role of quantification of scar burden is for potentially risk stratifying? Is that something that you use?
I think that's a really good question. So it's less like, so obviously in HOCM, where we've got this more well-defined burden, about 15%, there is interest in trying to come up with a specific threshold. And there's sort of papers coming out all the time where they say maybe 4%, maybe 7%. I think this is something we've yet to coalesce around. And so again, it has to be sort of, if there's a lot of late gadolinium, if you do your sort of your VT stim study to look and try and assess their risk further, I think it's not something that's well defined, but definitely you are trying to look at burden, even if you don't have a number attached.
I think one thing that's quite important that I've learned over the last couple of years is about sarcoid patients who've got a pacing indication, to give them an ICD rather than a standard dual chamber pacemaker.
Yeah, so people who qualify for a pacemaker indication because of that increased arrhythmia risk, it's also recommended that you consider ICD.
Yeah, and I've got at least 2 patients who got the ICD when they had a pacing indication and then had a therapy within about 6 months. So I've got a tricky question online. So should everyone who is diagnosed with sarcoidosis undergo cardiac screening in the absence of clear cardiac symptoms? If so, does one screen with troponin, BNP, ECG, echo, MRI, or PET, or all of them?
That's a good question. So yes, everyone should be screened, but how you do it is more variable. So the BTS, the British Thoracic Society guidelines, say ECG and echo is your baseline screening. You can also add in your cardiac biomarkers like troponin. Then if you see an abnormality on those, you would proceed on to your MRI and PET, not as your first line. So that's sort of where things stand. But clearly MRI is picking up quite a lot of things that echo and ECG don't because they're not as sensitive. So I think there is a move towards trying to use MRI more as a screening tool than currently there is. But again, not that well evidence-based right now.
Yeah. I mean, a normal echo doesn't rule out cardiac sarcoid.
Exactly, because all that will give you is structural information, no scarring, no fibrosis, inflammation.
Okay, great. Any more questions? Shooty. Just wait for the microphone. Sorry.
Thank you. That was a great talk. Do you tend to use any advanced imaging at follow-up when these patients come to clinics? So do you tend to repeat MRI or PET imaging or anything?
So I would say at the moment we follow the guidelines of the repeat PET imaging. Another thing is obviously these people have quite a high device rate, so the MRIs are more difficult once the device is in, not impossible, but more difficult. I think there is growing interest in using serial MRI as follow-up, but I think there needs to be more evidence before that's a standard thing.
Thank you.
I've got a last question.
Yes.
If you got physiological FDG uptake, what does steroids do to it?
I don't know the answer to that.
They turn it off. And so I think that there's like it just comes back to that problem for false positive FDG. And people say, oh, well, yeah, there was FDG and we gave them steroids and it turned it off. But that's because that's what steroids do to the myocardium.
Exactly. And I know we've talked a lot about new traces today. I didn't really mention that, but obviously I think dotate's probably the one with the most evidence behind it so far. And maybe that will be something we go forward to.
Great. Pia, last question. Quick.
In the sarcoid cohort, if a patient has like diabetes and like if their blood glucose control is all like deranged and not under control, would that have a role would that mess up the FDG PET pictures?
So I think you are more likely to have more of a diffuse uptake, but we check that they have diabetics have their own special protocol. They still take a lot of the medications and everyone has blood glucose taken before the scan. And if it's too high, then you would say, actually, maybe we're not going to go forward with it. So it is something that people think about, but there is always that in the back of your mind that you have to have suppressed, and your systemic glucose is a good marker.